Hello, everybody. Welcome on this live webinar. Well, I hope we all have a good and stable internet connection because without internet, it's not going to function, of course. So let's hope we don't face any technical problems. I also hope you're in a relaxed environment at this moment, that you can really focus on this webinar. We're going to take about 1 hour and 15 minutes today. So many people registered, about 360 people from all over the world. And of course, not everybody can attend this webinar live for the simple reason that for some of you it's very early in the morning and for some of you it's very late in the evening. But don't worry, everybody's going to receive an email after this live broadcast with a replay link of the webinar, so you can watch the webinar whenever you want, how many times you want. So for those of you who don't know me yet, I'm Stephen. I'm responsible for the Global Celiac Institute, and together with my international teaching team, some doctors and physios from Italy, Slovenia, Poland, Bangladesh, Argentina. We teach courses in orthopedic medicine all over the world. And of course, last year we didn't have so many live courses, but slowly but surely we restart the live events, fortunately. And personally, I have been teaching until now in about 37 countries for about 25 years. And this is still my passion. I really want to share my experience and views with you, so that you and me, that all of us, we can become, let's say, more inspired and better musculoskeletal therapists. And as usual, today I'm broadcasting from our international training center over here in De Haan. That's in the middle of the Belgian coast. And it's also over here that once per year I offer the Mastermind private training in orthopedic medicine. This is a very special course, just for 4 participants, maximum 4 participants. So this is worldwide unique. If you would like to have more information about that, you just go to the website celiac.eu/mastermind, and you can find all the information over there. But today, what are we going to do today? Well, today I would like to share with you a manipulation story, more specifically manipulation in the lumbar spine. But the first question we have to ask ourselves is, okay, why do we manipulate? What's your purpose? Well, some people, they manipulate to reposition something, or to reduce disc protrusion, or to activate some nervous stimulation, also visceral manipulation. There are so many different hypotheses, theories, indications. Actually, if you look at the whole manipulation world, it's quite confusing. Depending on what exactly is your purpose, of course, we're going to use different strategies, different techniques. And we also have to be honest that, okay, not every strategy is as valid as the other one. So we not only use our hands, but we also have to use our brain. And more specifically, what is happening when we manipulate the patient? What is happening? So today, I'm not going to bother you with all kinds of scientific considerations and a lot of references. Those of you who already know me, you know that I don't do that. I don't lose time with that. I'm happy to talk about scientific considerations and the latest updates during live courses when we meet face to face and we can discuss with a lot of pleasure. But during my webinars and online training programs, I prefer to stick to what really matters, what is really more interesting for you and me as a clinician. If in the meantime you have some questions, feel free to use the chat. I'm alone here, so I have to focus on my presentation and the technical part, but with one eye I also look once in a while at the chat, and I see that in the meantime many people from different countries already joined the live events, so welcome. So if you have a question in the mean, you can put it in the chat, and later I come back to it. But okay, what is happening when we manipulate? Is it really possible that we can reposition something, that we can, for instance, reduce some kind of disc protrusion? Is that possible? Perhaps. But perhaps also something else is happening. Perhaps something else is happening in our brain. Yeah, perhaps there are also neurophysiological mechanisms which are activated when we do some kind of manipulation. Well, does that happen? Well, the answer is yes, it happens. I'm just going to show you a few references, not more, but yes, indeed, references show that the effect of manipulation mainly is, let's say, biomechanical. Something is changing, but you also have neurophysiological effects. Yeah. Of course, the thing which is interesting me the most when I'm going to talk about indications and contraindications of manipulation, then we're going to see that manipulation could be interesting to reduce some kind of internal derangement. And does that happen? Yes, it happens. Does it always happen? Of course not. If you would like to have more details about the neurophysiological mechanism, well, there they are. I wish you a lot of fun with that. When you read this, to be honest, it doesn't interest me. Yeah, okay. It's what it's happening on the neurophysiological field. Nice, okay, nice data, nice theory, but as a clinician, okay, I don't care. I know it happens and I can't influence it, but okay, nice to know, but not necessarily need to know. Okay? What am I going to do today with you? I'm going to briefly talk about the specific indications and contraindications of lumbar manipulation. Very important. Yeah. Then I'm going to show you some techniques. I'm going to show you the practical procedure. I'm going to show you some films on how you perform certain manipulation techniques. And then the most important part for today is the strategy. When are you going to use which technique? How many times? When are you going to adapt? How are you going to adapt? This is something that apparently many therapists along the world are, let's say, neglect a little bit, but this is the most important thing. But okay, first, the question we ask ourselves, do we really manipulate what we think we manipulate? Yeah. I'm always, during live courses, I'm always confronted with the same questions that come back. For instance, when we examine the patient, we come to hopefully a relevant conclusion. And when you already watched my previous webinars or when you join the online masterclass, and I'm going to give you some information about that later on. So when you already viewed the complete lumbar course, then you know that real objective sacroiliac problems are not so frequent. Yeah. But then sometimes people tell me, yes, but I manipulated the sacroiliac joint and the patient was better afterwards. Okay. It's possible. Yeah. But then I ask, show me the manipulation. And then you see maneuvers like, as you see on the slide over here, and certainly the black and white slide. Yeah, yes, this is a sacroiliac manipulation, but also all the rest. This is not a specific manipulation. You also have influence on L5, S1, L4, L5, L3, L4. So the concept of specific manipulation in the spine, sorry, does not exist. Or I'm going to focus, I'm going to do a specific manipulation between L4, L5 to take care of a kind of hypomobility over there, whatever. Yes, feel free to believe that. But specific manipulation does not exist. You also automatically have effect on the level above and on the level below. So that's something we have to realize. So with sacroiliac manipulations, you also have a lot of influence in the lumbar spine. And vice versa. With a lot of lumbar manipulations, you can also have influence on other levels, for instance, also in the sacroiliac joint. So we have to be, I advise to be a little bit more objective on that field. Because let's be honest, there are dozens of different manipulation techniques and procedures. But if you look at, let's say, the validity of certain maneuvers, well, I think that some of those maneuvers belong over there. And this is a picture taken in Euro Disney in Paris, the European Disneyland. Well, what do I mean by that? Some maneuvers, they look great, they look fantastic, they look complicated, but they are nothing more than fantasy. So the question is, can we optimize our manipulative strategy? Can we make our manipulative strategy also easier? Well, I think we can. But okay, before you manipulate, you need to know, of course, why. What are my indications? Yeah. And today I'm going to focus on only one indication. Yeah. But a very important indication. A disc protrusion without contraindication. Great. What does that mean? Okay, what is our definition of a disc protrusion? We talk about an internal derangement. An internal derangement, a discodural conflict or a disco-radicular conflict, which is symptomatic, because we have to be honest, yeah, many disco or many internal derangements are simply not symptomatic. Okay, how are you going to know that? Well, of course, you have to interpret your examination in a relevant way, in a correct way. And this is something I'm not going to illustrate in this webinar, because in this webinar I'm going to focus on the manipulation. But if you're really interested in the detailed diagnostic process, then I refer to my other webinars and to the online learning program. More about that later. So, which internal derangement is suitable? Well, an annular internal derangement. We have actually two types of internal derangement. Well, we have more types, but we have an annular one and we have a nuclear one. Yeah, more details about that also in the diagnostic online classes. I don't want it to be too big. For instance, somebody who has a sciatica with clear motor deficit, that means that the pressure on the nerve root is too big. Forget manipulation. Yeah, you have a lot of chance that manipulation will not be successful. If the internal derangement is too far lateral, for instance, also clear sciatica, well, we have less chances to be successful. The more central an internal derangement, the more chances you have to be successful. This is just pure biomechanics. Yeah. I also don't want a patient who has too much fear. I respect the fear of the patient. And before I do whatever maneuver, I always ask for consent of the patient. I'm never going to put the patient on the treatment table and, let's say, attack the patient with some maneuvers without prior information and without prior consent. I always ask to the patient, well, I would like to try something with you. Yeah. What do you think? Can I do that? May I do that? And of course, most of the patients say, yeah, of course. Yeah, that's why I'm here. But occasionally, a patient is saying, no, I prefer you don't do that. Don't go against the will of the patient. Of course, I'm curious. Of course, I'm going to ask him, well, why? And mostly, those patients, they had some kind of bad experience in the past. And they are afraid that this bad experience is going to happen again today. So I would like to reassure my patient, but I'm not going to go against his will. Okay. And of course, I also need a patient who is really motivated to get better. Yeah, of course, that's logical. Which patient doesn't want to get better? Well, there are exceptions. Yeah. Perhaps with some patients, there are more psychogenic components. Of course, I don't think of an active therapy such as manipulation for those patients. But this is, of course, something we have to discover in our functional examination. We have to interpret the history, the inspection, the examination in a correct way to come to the conclusion, aha, is my patient suitable for this strategy, yes or no? Yeah. And as I mentioned before, the more central an internal derangement, the more chances you have to reduce. The more lateral, the less chances. As you see over there on the slide with the sciatica, lateral disc protrusion with pressure against a nerve root, we have about 1/3 chance that we can reduce by manipulation. So that's something you know in advance, yeah? And perhaps that's also something interesting to share with the patient. But okay, how do I know? How do I know? We have an internal derangement which is not contraindicated. Of course, we get all our information from the specific history of the patient. We get all the information from the functional examination. And okay, now I'm not going to go in detail over here because this is part of the other online courses on the lumbar spine. But if you watch my films on the diagnosis in the lumbar spine, well, it's a few hours of films where I share with you all the details of interpretation of the history, the inspection, the functional examination. This is going to be our main source of information on the basis of which we're going to decide, okay, are you suitable for manipulation? Yes or no. But perhaps I can illustrate briefly some things. Let's imagine a patient who has back pain, and he doesn't have a lot of radiation of pain. He has a slight partial articular pattern. And what does that mean? Well, very, very shortly, we do some tests in standing. We ask the patient to perform an extension, side flexion, flexion. And you can also ask the patient to do that in a repetitive way, of course. And when the patient did those movements, we see a certain pattern. And in the spine, we make a differentiation between two types of patterns, a full articular pattern and a partial articular pattern. And what is the definition of a full articular pattern? Well, the full articular pattern, what do you see? Extension and side flexions are equally limited, and flexion is the best movement. So one more time. Extension and side flexions in standing are equally limited, and flexion is the best movement. When you see this pattern, this is the typical pattern for arthritis. If you have grandparents of, let's say, 85 years old, just do those movements with your grandparents, and you're going to find this pattern in your grandparents. What is a partial articular pattern? Everything which is not a full articular pattern. Any other combination. Oh, extension, painful, limited, side flexion to the left, flexion, not too bad. Any other combination. So if we see a patient with back pain, clinically, a partial articular pattern with not too much limitation of movement, favorable signs. And what is the definition of favorable signs? For instance, extension in standing does not provoke leg pain. Side flexion in standing does not provoke leg pain. This is favorable. Yeah? And perhaps you find a painful arc on flexion and a painful arc on the straight leg raise. This is super. When you see that patient with those characteristics, this is going to be your best patient for manipulation. You're going to be successful very fast. This is the super patient. But it's all about selection. For instance, a sciatica patient, as I told you before, I don't want a sciatica patient to have a motor deficit. And if he has a limitation of the straight leg raise, I don't want him to have a big limitation of the straight leg raise. And so on, and so on. So those clinical reasoning elements, well, you really have to discover that in our live courses or in my online courses, because this is really such valuable information we all need for the future. Yeah. Okay, but that's just a brief overview. And when are we not going to manipulate? Well, if there is no symptomatic internal derangement, why should I manipulate? Why should I? The concept of preventive manipulation, well, we're going to do some manipulation, every 2 months to loosen up the spine. Yeah, okay. Yeah, if you're happy with that. But I don't do that. I just do it when it is really indicated. And then there are some other situations, as you can see on the screen, which are not suitable for manipulation. One important detail, never forget in the history to ask if the patient takes anticoagulant medication. If this is the case, and the patient, for instance, had a heart condition or a thrombosis or whatever, and as from now he takes anticoagulant medication, forget manipulation. Don't take any risk. How big is the risk that something goes wrong? I don't know. But I don't want to take the risk. Yeah, okay. Yeah, there is a minimal risk that we create an intraspinal hematoma, but I don't want to take it. Yeah, okay. So anticoagulant medications, you better look for an alternative. Yeah, okay. And sometimes we don't have a real contraindication, but we have some situations where manipulation doesn't make sense, where it's useless. And the most obvious example is, of course, it's too painful. You don't have to be a torturer. If the patient has a wonderful acute lumbago, he has a lot of pain, a lot of radiation, a lot of limitation of movement, very explicit partial articular pattern, and so on. Sometimes just putting the patient on the treatment table in the starting position for the manipulation is already problematic. So let's not do that. A patient with a very explicit deviation, for instance, a patient with a very explicit lateral deviation, and perhaps some of you already watched my previous webinars or already joined the online masterclass, and then you remember that at a certain moment I illustrated you what is the clinical relevance of a lateral deviation? Where is it coming from? How do we interpret that? What is the importance of it? Actually, it's super important. It means that most likely the patient has a pretty big internal derangement. And perhaps at this stage, manipulation is going to be a little bit unpleasant. Another example I would like to give you, what you see on the screen, over half of the spontaneous cure. What do I mean by that? Let's imagine the patient has a sciatica, a lateral protrusion with pressure against the nerve root. Well, I have good news, because those kinds of sciatica, they seem to have a spontaneous evolution. That means that symptoms in due time automatically disappear. And after how much time? Well, after about 8 to 12 months of leg pain, root pain, no back pain, symptoms disappear. And why? Because this internal derangement, this protrusion is, let's say, is resorbing. There are quite a lot of scientific references about that. And the interesting point is, in the first half of this evolution, the first, let's say, 5-6 months, we still have some chances to reduce an internal derangement. If we are later, doesn't work anymore, doesn't function anymore. Yeah. So if you see the patient, a sciatica patient, he already has, let's say, 6 months of leg pain, then you already know in advance that manipulation most likely, and also mechanical traction, that's something else, is not going to be very useful. You see, there are many clinical details which are important to decide, am I going to manipulate, yes or no? And not just the things you claim to feel with your hands. So your functional examination, the interpretation of your history, everything is super important. So in other words, it's all about patient selection. This is a key factor in orthopedic medicine. Okay. So, well, talking about patient selection, I already mentioned briefly my other webinars and the online masterclass. Well, before I show you the live version of some manipulation techniques, I would like to show you something else. Let's share my screen with you. Okay, I'm going to disappear a little moment. Okay. And if everything is okay, then now you should see my screen, and more specifically the screen of the orthopedic medicine masterclass. Yeah, when you surf to orthopedicmedicine.eu, you're going to see this. Okay. Well, I would like to share something interesting with you, because now you can also get access to much more information regarding clinical reasoning, and the beauty is it's partly free access. Actually, this masterclass is an online toolbox, about 17 modules, in which I focus on what is really important for us as a clinician about the inspection, the history, the functional examination, clinical reasoning, treatment strategy. Yeah. And I have a free discovery course over here. I have about 14 lessons in this discovery course. And how can you have access to the discovery course? Well, you just click over here and then you can make an account. But of course, I already have an account, so I'm going to log in, and then you're going to see what we can do. Yeah, then you just click over here, and okay, let's have a look at this lesson. Voila, you just start. This is a lesson of 23 minutes. Let's have a look at the diagnostic interpretation of an arthritis in the shoulder. Well, before we do that, if you want to have a look at another lesson, well, you just choose another lesson, and this is a lesson of 17 minutes, and so on, and so on. So it's very easy to get a free account over there. I suggest if you didn't do it yet, well, do it. And then we have 10 masterclass silver courses, and you can have a look at all the different lessons. And we have 6 masterclass gold courses, and there's 2 extra things I would like to show you. In the Masterclass Gold, I also put all the previous webinars I gave. You can watch them again over here, but there are also some PowerPoint podcasts on actual subjects, like, for instance, how to understand and to deal with tendinous problems, the actual status. Another thing which might be interesting, there are a lot of downloads. For instance, all the different course handouts. Yeah, you just click over here and automatically you can download all the well illustrated course handouts with all the information, so you can have a look at it in a relaxed way. And again, all those course handouts, you're not going to find any scientific references. It's just practical information. Okay? So, I'm back. Voila. If you would like to sign in for this free discovery course, I'm going to give you a link, and just let me activate this link for you. Well, okay. If you look on the right side of your screen, you're going to see the link to make your personal account. So feel free to do that, and then you have immediate access, unlimited access, as much as you want on your PC, on your tablet, on your smartphone. And take some time to have a look at the discovery courses, because it's already a few hours of film material. So just for you. Okay. Good. Okay, we're going to manipulate if the patient has some symptomatic internal derangement. But in the introduction, I told you that, of course, there are a lot of different kind of manipulation techniques. Yeah. As specific techniques, and this is now something which is very important. Many of us, we are familiar with a lot of techniques where therapists are, let's say, lock the spine until a certain level and then do some kind of segmental local manipulation. Yes, but then we have to ask ourselves, actually, the patient has an internal derangement. But many therapists are so focused on labeling the patient or labeling the pathology. There is a problem on L4, L5, there on the left side, whatever. But the problem is, in the lumbar spine, to put labels on the patient is really very difficult, and mostly that doesn't make any sense. So we have an specific diagnosis. Yes, I have a lot of information from my clinical reasoning process to suspect the patient has a symptomatic internal derangement. Yes. But don't ask me where. Is it an L4 disc, an L3 disc, an L5 disc? I don't know. And mostly I don't know. In case of a certain sciatica, I can know that, but mostly when there's a discodural conflict, I don't know. And you know what is the good news? I don't need to know. This is actually irrelevant information. So when we're going to manipulate, do I need a specific technique? No. Perhaps I'm going to be more successful with specific techniques. Don't understand me wrong. I don't say that the so-called specific techniques are not good. I just say, perhaps when you use an specific technique, perhaps it's going to be a little bit more efficient, or it's going to be easier. Perhaps. There's something to think about. Okay. I'm just going to have a brief look at the chat now to see if there's already some questions. Maria is asking, hi Stephen, is it an absolute contraindication for manipulation if the patient has anticoagulant therapy? For example, the patient has anticoagulation therapy for a long time, for years, and now they have a musculoskeletal problem. Well, if the patient takes, let's say, just cardioaspirin, a moderate anticoagulant, that's not a big problem. But if the patient takes real heavy anticoagulants and he's under the doctor's guidance for that, and sometimes they have to adapt their doses, then certainly don't do it. Yeah, but better safe than sorry. If you have any doubts, contact the patient's doctor, talk about it, and to know how severe is the situation. Yeah, okay. Better safe than sorry. Well, time for the first manipulation technique. We call this first manipulation technique the stretch manipulation. And as you can see, this is super specific. The patient at the beginning lies with the painful side up, yeah. And the therapist is in fact going to bring his or her body weight above the patient in order to create some traction component. And then we're going to, during the manipulation, we're going to increase the traction component. And the important thing is that during this manipulation, the secret is take up the slack before and don't lose your pretension. The secret of good manipulation is pretension. Okay, well, let's make life easy. I'm going to show you this manipulation on film. Okay.
The treatment table is positioned as low as possible. If possible, maximum height of 45 centimeters. Starting position. For a unilateral pain, the patient lies on the painless side. For a central pain, he can lie on either side, or a choice is made according to which straight leg raise is worse. The lower leg is extended. The upper leg is flexed, with the foot behind the back of the other knee. Grip. One hand behind the greater trochanter with the fingers pointing caudally, the other hand at the front of the shoulder with the fingers pointing cephally. The therapist's feet are apart. Avoid gliding on the skin. 3 components have to be built in. First, shoulder and pelvic rotation, both rotations being equal. Then the therapist adds a longitudinal taking up of the slack, rising on tiptoe and using his body weight exactly above the patient's trunk with his arms extended. This taking up of the slack is followed by the manipulative thrust. While maintaining the distraction, part of his body weight is used as a pelvic swing in a longitudinal direction of the flexed upper limb of the patient. frequently made errors: losing the pre-tension before manipulating, pelvic swing movement in the wrong direction, and too much pelvic rotation in the swing movement. In the more nuclear variant of the stretch, no thrust is given. We maintain the distracted position for some time, and after 2-3 executions the effect is assessed. The maneuver can then be repeated.
Okay. So this is one option. It's actually a very popular manipulation technique. To be honest, technically it's also one of the more difficult techniques. But this is going to be your basic technique. Remember, later I'm going to talk about the strategy. I come back to that. Okay. Another option is something similar, but in that case, we call that maneuver the leg over. And in that case, we're going to use the leg as an extra lever. So that's a little bit more intensive than the previous one. One little detail. If the patient has osteoporosis, don't do it, okay? You don't want to provoke a femur fracture, okay? Or let's say the patient had a long-standing cortisone medication, and because of that there is osteoporosis. Please check that, okay? We don't want any accidents. Well, I can also show you this maneuver on film. Yeah.
Starting position. One should estimate the correct supine position of the patient. If the patient lies too far towards the opposite side, then during the manipulation the leg catches the treatment table, blocking the manipulative movement. If the patient lies too close to the therapist, then he's going to fall off the table. So we look for a mid position. The therapist stands at the pain-free side. Execution. Let us assume that the left side is the painful one. The therapist grasps the left knee with both hands, flexes the hip to about 90 degrees and under traction, more comfort for the patient, brings the patient's knee to well below the edge of the couch. The patient's left hand lies on his abdomen. The patient has the impression that he will fall off the couch and therefore tries to hold himself onto it. This is not necessary at all. Make sure that the patient's thigh does not engage against the edge of the couch. So the therapist brings the knee far down, turns his hand outwards, and now stands with both legs apart, facing the patient's feet. Taking up the slack is as follows. The therapist brings his left foot against his right one and uses his body weight onto the patient's right shoulder. He makes sure that the knee remains down so as not to lose the pre-tension. The manipulative thrust is a quick push downwards with the hand on the knee. For an upper lumbar protrusion, more hip flexion can be built in.
Okay, so that was the second option, which is also pretty popular option. There's also a variation on this leg over manipulation, which we call the Dallison. But okay, what's in the name? In the States, they call this technique the pretzel technique. Yeah? And actually, you see that it looks like a leg over, but we incorporate some kind of side flexion. So it's a leg over with a side flexion. And why do we do that? Well, we do that specifically in patients who have also a lateral deviation. So let's imagine the patient has a left lateral deviation, regardless from where the pain is. The pain can be on the right side or the left side. That's not important. But the patient has a left deviation. So what are we going to do? The therapist is going to stand on the left side of the patient. He's going to cross over the left knee. Then he builds in a side flexion, thanks to a swinging movement, and then just continue like the leg over. And this is also another option. I have to be honest, the stretch and the leg over until now are, let's say, the more frequently used techniques. Other options are, for instance, a central extension technique. And the previous techniques were, let's say, pretty specific, as I mentioned before. This is perhaps a little bit more specific, but I don't like the word specific because it's not correct. Let's say this technique is a little bit more focused in a certain area. One thing I can already tell you, don't do this kind of manipulation when the patient has an acute lumbago. When the patient has a flexion deviation, there's quite a lot of pain, and a flexion deviation. Just being in prone lying is already going to be pretty painful for him. If we then would do an extension manipulation, you may be sure that the patient is not going to be happy. Yeah. And there are two versions. We have a central extension technique where we take a contact between two spinous processes. And we can also have a contact on a transverse process. Then we have a more unilateral extension technique. Also an option. And a next option I would like to show you is the reverse stretch manipulation. And to be honest, this is also one of my favorites. Again, a very specific technique. It's exactly the same as the stretch, but in a reverse way. So, and this one I also have on film for you. So let's have a look where I can find the film.
The treatment table is in the lowest possible position. The patient lies on the pain-free side with the lower arm behind the back. The upper arm hangs relaxed off the table. The upper leg is brought backwards and hooked behind the edge of the couch. Execution. The therapist stands in cranial direction. Again, the slack is taken up in rotation. The therapist uses one hand, fingers upwards, against the anterior superior iliac spine to obtain pelvic rotation, and maintains it by extending his elbow. With the other hand, against the spine of the scapula, he builds in the other rotation. Both rotations should be equal. The second element is the distraction. The therapist faces the patient's head, rises on tiptoe, stands on one leg, and brings his body weight above the patient in a longitudinal direction. The manipulative thrust is a downward jerk towards distraction, using the body weight, keeping the arms straightened.
Okay, so this is also a very nice maneuver. I have a quick look at the chat again, and I see there is a question from Luca. And yeah, we know each other, Luca, because Luca was one of my guests over here in the training center for the exclusive Mastermind private training. So we had a nice times together. And Luca is asking, okay, how can I practice this swing movement of the stretch manipulation? Well, okay, I'm going to try to give you a little tip. Just a moment. So I go to full screen. I'm going to do something strange now, but I hope it works. Okay. So what do? Take a contact on the treatment table without the patient. Bring your body weight above the treatment table, and then you do your swing and try to hit with your legs the treatment table. Yeah. So you build in, so to speak, the pre-tension, up and hit the table. Do that several times, yeah, until you have the feeling that you have a good swing, and then you do it with the patient. Okay, in my experience, that's something that works. Okay, so as you see here, the reverse stretch, it's really important that you really bring your body weight above the patient. And one little detail, many patients, they feel something somewhere in the thoracic spine, somewhere between the scapulae. They feel something over there. Of course, during this technique, which is an A-specific technique, this is completely normal. Okay, and then, so that was an overview of some techniques, but then the major question is, which manipulation am I going to do, when, and how many times? This is the key information, okay? But before I share those secrets with you, remember, go to orthopedicmedicine.eu and go for your free discovery course. Yeah? And if you look on the right side of your screen, you're going to see that some offer is appearing. I told you discovery is a lot of information for free. If you really want to continue with the silver course and the gold course, well, in the silver course, you have 59 courses, and the price you can see on the screen is €199. If you upgrade to gold, so then you have all the downloads, have everything about the lumbar spine, the complete package, all the webinars, everything, and the updates, because I'm constantly adding new information, then it's €99 extra, and you have unlimited access on your tablet and smartphone, and of course also on your PC. But because you attend this webinar here today, I have something special for you. You get the complete package. You get Masterclass Gold for free. But this is an offer which is valid for the first 10 participants here during the live version. But I also would like to give a chance to those people who watch the webinar in replay version. So the first 10 live and the first 10 in the replay version, you can use the discount code FREEGOLD and upgrade for free to Masterclass Gold. So just click on the link which you see on the right side of your screen, and then you can automatically sign in for this Masterclass. Immediately after signing in, you receive your login data, and of course you also receive an official invoice for your accountancy. So join the Masterclass, okay? But let's go back to the manipulative strategy. Yeah. Well, some general rules. First, some general rules. With elderly patients or with osteoporotic patients, you're not going to use techniques with the lever. So, leg over and the Dallison is forbidden. We're going to do less number of manipulations per session, and this is subjective. What is the definition of less manipulations? That's, let's say, 3-4 manipulations in one session. This is enough. And we're going to have a greater interval in between the manipulation sessions. Perhaps he's not coming back tomorrow, he's coming back in 2 days. But this is, to be honest, subjective. But what is not subjective is something I just mentioned before. The acute lumbago patient, a big posterocentral internal derangement with pressure against dura, and the patient has a flexion deviation, you don't do extension techniques. Yeah? Remember the patient in prone lying and hopla. This is torture. Don't do that. And when we decide to manipulate, so remember the patient is falling into our indications, we always start with the first maneuver, the stretch manipulation. This is always start maneuver. So that's why this manipulation is so important. Yeah. So you start with the stretch. You do it once. Super important. You do it once. And after the first time, you check after the manipulation. And what do you check? You check what was positive in your examination. Let's imagine some test in standing. Okay, if some tests are positive in standing, okay, check the positive test. Something happened with the pain, something happened with the range of motion, check it. If the straight leg raise was positive, check the straight leg raise. Yeah, okay. So that's why your functional examination is so important. So you do it once. You check your test. Is the test better? Hey, that's a winning team. So what do you do then? You continue. You do the same stretch again, and perhaps a little bit more intensive. Yeah. But at a certain moment, it's not going to be extra better anymore. You did one stretch, you did the second one, perhaps you did the third one, and every time you check. Yeah, because this is important. Every time you check, if you do 5 manipulations, you check 5 times. We're not going to do it like this, that the patient is on the table and we do a series of maneuvers, and then we're going to see what happens. No. If the patient is better, you don't know why he's better. But if the patient is worse, you don't know why he's worse. Is it because of your technique number 1, technique number 2, technique number 3? I don't know. Yeah. So that's why, general rule, 1 manipulation, test. 1 manipulation, test. Always. But of course, a certain moment, let's say the possibilities of the stretch, they come to an end, and it is not extra better anymore. What do we do then? Well, then we're going to change technique. Okay. Which technique? I'll show you later. But in the meantime, I keep an eye on the chat again, and there are some questions about this online masterclass. The question, is it unlimited for lifetime or just until 1 April 2022? Well, you get a license. This promotion I offer you is a license, unlimited access until 1 April 22. So you have more than enough time to watch this super treasury of information. But what happens after 1 April 22? Well, of course, you can extend your license. And what I already can tell you now is that if people after 1 April 22 want to extend their license, you can have full access again to the complete platform for just 49 euros. So for a very, very, very moderate amount. But of course, I'm going to inform you about that in due time. Okay, I hope this is an answer to your question. So we did the stretch. Better, we do it again. Better, we do it again. Not better, we change. But what is the definition of better? This is important, huh? Well, I can already tell you that the definition of better is not what we feel or what we think that we feel with our fingers. Yeah. Because you're also going to notice in the complete lumbar spine course that what we think with our fingers, that, or what we feel with our fingers, that's mainly something we think we feel. This information very often is less relevant. So what is better? Well, we do the test movement. And the patient says, I have less pain on doing the test movement. Or you do the test movement and there's more range of motion. Or less test movements are positive. Let's imagine the straight leg raise was positive and some test movements in standing. And now on checking, the straight leg raise is negative, but the tests in standing are still positive. Or, an absolute favorite, there is a centralization of the pain. Yeah, let's imagine, okay, I go to full screen again. Yeah, let's imagine the pain. The patient has pain over here and some radiation in that direction. Yeah, okay, and we do manipulation. Test movements are better, but you see on the face of the patient that he's not happy, although the movements are better. And why is he not happy? Because now he has pain over here. He says, I have back pain. And he didn't have back pain before. Yeah, he had pain over here with radiation over there. But after your manipulation, you get pain over here. But what happened with this pain? This pain disappeared. So in the perception of the patient, this is not so good. Now I feel my back, but I didn't feel my back before. But actually, this is centralization. And we are big lovers of centralization. Yeah, when it's centralized, whatever you're doing, centralization is a positive, is a good sign. Whatever exercise the patient is doing, whatever technique you are doing, if we get centralization, we love it. Okay. And another definition of better is the appearance of a painful arc. Let's imagine flexion. Flexion in standing was painful and limited. But now we find a painful arc. Or the straight leg raise was painful, and now we have a painful arc on the straight leg raise. Yeah? So this is better. Okay? So this is the, let's say, the global strategy for manipulation. Yeah, if there is one slide you remember from today, it's going to be this slide. Actually, we have three highways. Yeah, we always, as you know, we always start with the stretch, and as long as it is better, you continue. But at a certain moment, it's not extra better. So what you do then you go to the leg over. And you do the leg over as long as it's better. And perhaps, if necessary, then you can continue with the Dallison. But to be honest, with many, let's say, with many moderate internal derangements, with many small internal derangements, stretch and leg over, that's mostly enough. Let's imagine today you ended your treatment stress session with the Dallison manipulation, so the last one. And the patient comes back tomorrow or the day after tomorrow. Do you continue with the Dallison? No. The next day is a new day. So the first thing you do, test again, the test in standing and the straight leg raise. And we start again with the stretch. And then it's possible that the patient says, well, yeah, it's not better. No change. Okay, try to do the stretch again. No change. Am I going to continue with the leg over then? No, I do something else. Then I go to the second track. I go to the reverse stretch. And then what we see, yes, now we have result. Actually, all those techniques, what happens, remember my introduction, the biomechanical effects, actually we are playing with a change in intradiscal pressures. And this change of intradiscal pressures is allowing that some kind of internal derangement is reducing more or less, so that we have a less discodural conflict or discoradicular conflict. But it's just a pressure game. And sometimes the patient reacts better on stretch, sometimes the patient reacts better on reverse stretch. And then we have a last track. Let's imagine you do the stretch, better, better, better. But a certain moment, not extra better. And then I choose for the extension technique. Why should I choose for the extension technique? Well, there's one good indication. If in the examination, the patient shows you a good extension, so extension is his best movement, and flexion is a little bit problematic. So if extension is a good movement, then most likely you're also going to be able to have a good, let's say, a comfortable manipulation and extension. But actually, my top 3 manipulations, the manipulations where I have most of the success, are stretch, leg over, reverse stretch. And as I mentioned before, you do the maneuvers with the painful side up. But is that a golden rule, the painful side up? Well, I have good news. No, that's not the golden rule. We started this way. But I told you, it's all about changing intradiscal pressures. It happens that I do the stretch. It's not better. I do the stretch again. It's not better. So normally I would go to the reverse stretch, okay? But now I don't do that. Now I experimented a little bit and then I do the stretch again, but with the painful side down. Now, what did I notice? Hey, it was better. Okay, never change a winning team, so continue with the painful side down. And then you can continue with leg over or with the reverse stretch. So there is no golden truth. Yeah, so playing with painful side up and painful side down gives you, let's say, extra possibilities. Okay. Good. Well, I'm going to have a look at the chat again. So that was pretty compressed, intensive information. And what do I see in the chat? Question: if the online masterclass, is there a certification? Yes, there is a certification if you go for Masterclass Gold. But in my offer, I offer it to you free. You can also do an extensive multiple choice test. That's 25 multiple choice questions, which you can answer. And on completing this, you will get a certificate stating that you did the online course so many hours, and so on and so on. So yes, we provide a certification. What else do we have? Then Roberto is asking for patients with posterolateral disc herniation, so in other words, sciatica, and an ascending protrusion. What is the protocol, traction or manipulation techniques? Well, the answer lies in the interpretation of the history and the functional examination, but mainly the history. The history is going to tell you, is it more a hard protrusion or is it more a soft protrusion? Well, I refer then to all the other online classes on this topic, but I can already tell you one little thing. If you ask to the patient, how did it start? And if the patient tells you he was doing a certain activity and suddenly I got a twinge in my back. For instance, he was doing some flexion rotation activity and then he comes up and I feel a twinge. Then mostly this points in the direction of a so-called annular internal derangement, and manipulation is going to be more successful. If he tells you, on the other hand, that the problems came on slowly, there's a lot of flexion rotation components, a lot of unidirectional, let's say, loading, and slowly the problems come on and slowly they get worse. This is more a nuclear story. We see that more with younger people, not that much with elderly people. So if you have this slow story, then I think more of the traction table. But also giving mechanical traction, we have specific indications and contraindications. Okay, what else do we have? Straight leg raise is sometimes limited by hamstring tightness, so it's not a clear picture. Yes, yes, that's possible. I'm a good example. I'm Mr. Stiff. If you do my straight leg raise, I'm going to have about 70 degrees of straight leg raise in normal situations, so I'm stiff. So it's all about the reproduction of the patient's symptoms. A positive straight leg raise does not necessarily have to provoke pain in the leg. And this is also one of the famous misinterpretations. Many positive straight leg raises produce pain in the back and not necessarily in the leg. Yeah? Again, I refer to the extensive clinical reasoning courses, but this is very important to know. Straight leg raise is not just a nerve root test for L4, L5, S1, S2, but it's also a dural test. Yeah. Of course, we're going to test it in a bilateral way, so that we can compare. And we're going to also add accessory neck flexion to the straight leg raise. And let's imagine that this provokes more the symptoms or reduces the symptoms, then of course you can exclude the hamstrings. But again, all those details you discover in the online masterclass or our live courses. The question how you define hard and soft protrusion, that's I just answered that. Is a previous microdiscectomy a contraindication for manipulation? Yes. It depends. If he got surgery, let's say 4 months ago, I don't think of manipulation. No. Most likely, persisting symptoms after manipulation have another reason. Yeah, most likely internal derangement is not a problem anymore, but the patient is going to have some kind of dysfunction syndrome. Again, I refer to the diagnostic classes. But let's imagine the patient had surgery 6 years ago and he was okay. Everything went fine. He was okay. He was happy. But since 3 weeks, he has again an acute phase of back pain. Well, just analyze the situation. History, inspection, functional examination. If he falls into your indications, there's no reason why I shouldn't manipulate him. Just analyze it as objectively as possible. Okay? So, do you have any more questions for me? Because slowly but surely we are reaching the end. As you can see on the screen, you have the links to the Mastermind, the online course, and the live courses. So we have different options for you to inspire you to become a really super musculoskeletal therapist. And Eric, I see your comment. Thank you very much for your kind comment. Well, yes, indeed, it is my passion, together with my team, to spread this valuable information, because I know that the word celiac sounds, for some people, that sounds really old-fashioned. Well, celiac, that's old news. But as you noticed here today in this webinar, actually, we're talking about basics. We're talking about objective clinical reasoning. We're talking about valuable information. And for those of you who know me, I'm not the man of the artificial hypercomplication. Yeah, I focus on the basics. But of course, without tunnel vision, we have to look in different directions. Okay, and then Abdel Hamid is asking, okay, the patient has a big lumbago and a lateral shift. What kind of manipulation we do? Well, if he falls in my indications, remember, if it's not too big, if it's not too acute, you start with the stretch manipulation. Yeah, as I showed you, you start with stretch. Better, better, better. You continue with the leg over, and then perhaps you continue with the Dallison. Just follow the strategy as I described. Then a question, videos of manipulation techniques will be shared with us. Well, all those videos are on the online masterclass. Actually, on the online masterclass I showed you, there are about, in the meantime, I think 23 or 24 hours of film. Yeah, all in little pieces, films from a few minutes until 35 minutes. Really designed for practical and efficient learning. You find everything online. And Luca is asking, what is the simplest reason to manipulate someone? I don't know. I don't understand 100% your question, but the simplest reason to manipulate someone is the patient has a symptomatic lumbar internal derangement. This is actually my only reason to manipulate someone. Okay, so my timing is good. I told you we're going to have a webinar of about 1 hour 15 minutes. Well, in the meantime, we have 1 hour and 16 minutes. So Eddie is asking, is there any option to sign up for free first time? Well, yes, this is the free discovery course. You already have 14 free lessons in the discovery. That's already a few hours of film. So just register, make your personal account, and you have immediate access to those 14 free lessons. And how long time can we access this free option? Well, there's no limit. There's when you register for the free option today, as long as you want, you have access to the free option. Okay? So, just to conclude, when you would like to go for the master, very easy steps. You go to orthopedicmedicine.eu, you click on Get Access, then you choose Masterclass Silver or whatever. Then you click the gold upgrade, you use your bonus code free gold, and then you click on the white arrow, you click on it to activate the bonus code, and then you just choose a payment method. Everything is possible: PayPal, credit card, whatever, transfer. And then with the confirmation, with the login data and your invoice. Okay, and Louis is saying, just finished the today, very good material and a lot of information to keep reviewing. Thank you, Stephen. Well, thank you, Louis. And indeed, I sent you an email yesterday with your certificate, and you did a very good test. You had a very good score on your test. So thank you very much for your kind feedback. This is why I do, just to inspire you so that I can share this experience with you, and also the reverse way, because don't forget, I also learn a lot from all of you. And I really hope we meet each other one day during a live event, and slowly but surely we're going to resume the live courses. So if you have any further questions, just send me an email, info@ciriax.eu, or you go to the website. We also have a support page. It's my pleasure to be at your service, so feel free. And of course, also in the online masterclass, there's also a support system directly from the masterclass. You can replay version of this webinar. Then there's also an email function in the replay version. You can immediately questions. And Abdelhamid is saying there is no Qatar on the list of country. Yeah, indeed. Let me go back to this slide. In the order procedure, you have to choose a country. And indeed, not every country is listed, but there is a solution. You just click on Other. Yeah, in the list, a certain moment, you're going to find Other. And if you just click Other, everything is okay. So, dear colleagues, thank you very much. I'm going to say goodbye to you with this beautiful statue here on the beach promenade in the Haan. Thank you so much for joining. I had fun. Hopefully it was also very fun and interesting for you, and perhaps we meet one day. So thank you very much for joining. All the best. Ciao, ciao. Bye-bye.